Welcome to the second lecture on the module on lens. Today we'll be covering congenital cataract. It's a very important topic, and I think we'll go through the etiology and then how you'll assess congenital cataract and then how to treat congenital cataract. So what is congenital cataract? If we look at it, it's opacity of the lens which is present at birth or that develops within the first year of life and occurs in about 3 in 10,000 live births. So we have to be very vigilant about this. Some lens opacity do not progress and they're usually insignificant. Others can produce profound visual impairment. So if we look at it, congenital cataract can be unilateral or bilateral. And 33 or 1/3 of them are idiopathic, which may be unilateral or bilateral. And 33% are inherited, while 33% are associated with systemic disease. The usually bilateral and other ocular anomalies are present in 50% of the cases. So what do we mean by ocular anomalies? It's like congenital malformation of the iris, which is called aniridia, coloboma. Those are nanophthalmos. So those are the ocular anomalies which we see in development. Let's look at the etiology of cataract, and we see it can be either unilateral or it can be bilateral. Unilateral, the number one cause can be idiopathic. Then you can have ocular anomalies, which we discussed before. Then we have lenticonus, in which there is conical projection of the posterior lens capsule. You have posterior polar tumors that can cause unilateral cataract. Persistent fetal vasculature. Normally, embryologically, when the child is developing, the lens usually gets its vascular supply from the hyaloid artery, which sort of regresses over as the child develops after he's born. So the vitreous becomes clear at that time or transparent. But if there's persistence of those vessels, then you can see a posterior persistent fetal vasculature. Trauma is a very important cause of unilateral cataract, and the type of cataract you get is pretty classical in trauma. You can have masked bilateral cataract, and rubella is another thing which we'll go through. It is another entity which is congenital rubella, which causes cataracts. Then the other thing which you can get is you can get them in both eyes. If you have them in both eyes, idiopathic still remains number one on the list. Hereditary. It can be autosomal dominant, autosomal recessive, and X-linked. So it's very important. Children who present with bilateral cataract, you need to ask them from the history, did your siblings or any other child have cataract or not? Genetic metabolic diseases, which we have gone through in the classification as well, those are very important. Then you have got chromosomal abnormalities, which include trisomy, which includes Down syndrome. You can get them with metabolic changes like hypoglycemia, hypoparathyroidism, which changes the calcium in the body, myotonic dystrophy, maternal infections, which is typically comes under the torch syndrome, which is toxoplasmosis, rubella, CMV, varicella, and syphilis. Then you have ocular anomalies, which we discussed before. Aniridia, they can either present as unilateral or bilateral. And then obviously toxic, which can be corticosteroids or radiation therapy, which can be a cause of them. Looking at where they're actually placed, it will depend where the pathology or when was the pathology originated. So it can be in one of the lamellae, as we've discussed before. It can be either at the poles, anterior pole or posterior pole, and produce an anterior or posterior polar cataract. They can either be a sutural cataract, which is not very visually significant, a coronary cataract around the nucleus in the cortex, a cerulean cataract, a capsular cataract, a complete or a membranous cataract. In a membranous cataract, the cortical matter is absorbed and you're just left with a membrane over there, and usually they're pretty tough to do surgery on. So causes, then we come on if we think of having cataracts in a neonate which is healthy. comes in, he doesn't have any other pathology. So you always look for other pathologies in the history, which will go as we go through the lecture. So hereditary are usually dominant because it is a trait which comes in that form. Then you have idiopathic with ocular anomalies, which we are discussed was persistent hyperplastic primary vitreous. And then the vitreous behind the lens is hyperplastic, it is white, and it causes leukocoria, whitish pupillary reflex, which you can be confused with cataract, which can be confused with retinoblastoma. So you need to identify that, and you will get sort of processes of iris coming onto the lens anteriorly as well. Coloboma is when the optic fissure does not close inferiorly and there's a defect in the lower part of the optic fissure. Microphthalmos, when the eye becomes smaller in size. And then we've got bophthalmos, which is glaucoma, secondary to glaucoma or raised intraocular pressure. So those are the causes in hereditary neonates or well neonates. And then you come into neonates, which are generally unwell. So obviously, the most important cause of cataract is the stress during intrauterine life. So you need to ask the mother, did you have rubella, toxoplasmosis, cytomegalovirus, varicella? And then the other causes are the metabolic causes. In those, the child is not very healthy and he'll be a sick child. And sometimes they're referred by the pediatrician to find out if they've got cataract or retinal problem associated with that. So metabolic disorders can be galactosemia, hypoglycemia, hypocalcemia, and Lowe syndrome. So those are the things which can cause metabolic problems. If we look at it through morphologically, we can look at it and see there can be a lamellar or zonular cataract. It is autosomal dominant trait. It affects on the visual acuity with the size and density of the opacity. In children, it is very important to see where the cataract is. If it is very small as in the center, usually it is not very significantly causing decrease in vision. And then there are opacifications of specific layers or zonules of the lens. They're visible as opacified layers that surround a clear center. And it's surrounded by a clear layer of cortex. So systemic association of a lamellar cataract are galactosemia, hypoglycemia, and hypocalcemia. So that is important to know. So this is just one lamella over here in which the cortex outside and the nucleus inside is healthy, but one lamella is involved. Then we come on to anterior polar cataract. So the opacity involves the subcapsular cortex and capsule of the anterior pole of the lens. It is autosomal dominant, small, bilateral, symmetrical, and non-progressive opacities. Here you can see, if you look, it looks like a small whitish opacity in the pupil. But when you do a slit lamp examination, this is a slit of the cornea. But when you look over here, it comes and shows you as an opacification of the anterior capsule of the lens. Then we come on to a posterior polar cataract. Produces more visual symptoms because it tends to be larger in size, and they may be sporadic or usually bilateral, and sporadic and might be unilateral. Ocular association include persistent persistent hyaloid remnants, posterior lenticonus, persistent hyperplastic vitreous, and here you can see the opacity is present, and usually it is very localized on the outside and you do not see any fuzzy margins to it. The important thing to remember in a posterior polar cataract is sometimes the vitreous is present in behind the defect in the posterior capsule associated with this posterior polar cataract. When you're doing surgery, you can get a posterior capsular rent pretty easily in these patients. And we come on to sutural or stellate cataract. They are visually not very significant, but there is a opacification of Y sutures of the fetal nucleus. So it is the fetal nucleus which gets opacified. So it means that the stress in the lens development occur at the fetal stage. It does not impair vision, and there are branches or knobs projecting out from them. Then we can get cortical spoke-like cataracts, which are associated with Fabry disease or monocytosis. Here we can see the spokes which are present. This is a spoke which is present, seen in the cortex. Then we have coronary cataract. So coronary comes from the word crown. They are autosomal dominant group of club-shaped opacities that are arranged around the equator of the lens. And they cannot be seen until the pupils are dilated, and they usually do not affect the visual acuity because here you can see they are outside the pupillary axis. Then you can have a central pulverulent cataract, which is autosomal dominant, spheroidal opacity within the nucleus. So means the stress occurs at a fetal nucleus stage in these cataracts. Rarely you have a clear center. So unlike a lamellar cataract, they do not have a clear center. But the good thing is they are non-progressive. Then this is cerulean or blue dot cataract, small bluish opacities located in the lens cortex. They are non-progressive and they usually do not cause visual impairment. This is very important to know by the shape of the opacity if they are causing visual impairment or not. Then we have capsular or total cataracts. Can be either small opacifications of the lens epithelium and anterior lens capsule that spare the cortex completely. All the lens fibers are opacified and red reflex is totally absent, and retina cannot be seen by direct ophthalmoscopy. In infants, direct ophthalmoscopy or indirect ophthalmoscopy is very important because you can put your eye to a direct ophthalmoscope and see through the red reflex if you can see the red reflex and how much of the opacity there is. But the most important thing is if you go forward, especially under examination under anesthesia, if you can take the ophthalmoscope forward and you can see the retinal details with a direct ophthalmoscope, that usually means that the patient does not need surgery because he'll have fairly good vision up to 6/12 in those patients. Because congenital cataract surgery is not as simple as adult surgery. It is associated with much more inflammation and you can get more complications which can lead to permanent loss of vision in that patient. So you have to plan it well, you have to treat it aggressively post-operatively to get a good visual outcome. So this is just a combined slide showing all the different types of cataracts, in which you start off with the lamellar, central pulverulent, this is the anterior polar, posterior polar, this is a coronary cataract, this is a focal dot cataract, this is lamellar, central pulverulent, sutural, and focal dots. Then just a cheat slide for you that we've already told you the different types of cataracts. So if you have one table in which you know, usually these are the type of tables from where you will generate MCQs. Like spoke-like opacities are seen in which cataracts? That's Fabry's disease. Vacuoles are seen in monocytosis and diabetes. Multicolor flecks are seen in hyperparathyroidism and myotonic dystrophy. Green sunflower cataract is a characteristic of Wilson disease. And thin disciform cataract is Lowe's disease, and lamellar cataract is seen in galactosemia and hypoglycemia. Now we'll go through the management, which is very different from adults. So what we want to see in the symptoms, parents usually bring them in with a white pupillary reflex. It is important to separate or do a differential diagnosis. A white pupillary reflex called leukocoria can be either due to a cataract or it can be due to a retinoblastoma. It can be due to a persistent primary hyperplastic vitreous. It can be due to total closed funnel retinal detachment seen with retinopathy of ROP. So if you see a white cataract, the first thing that comes into your mind is look at the patient. If it's healthy, ask from the history if there's any history of prematurity, and if not, you need to do a B-scan ultrasound before doing any surgery. So then you ask for his vision to check if does he recognize any objects or localizes light. Then important, does the patient have any nystagmus? If the child starts to have nystagmus, that means you're too late for cataract surgery. You need to do, if the patient has congenital cataract, you need to do it within 6 weeks, especially if it's a dense cataract. Otherwise, he'll start developing an nystagmus, which is a poor prognostic factor for visual recovery. Deviation of eyes. If he has developed a squint, that will be another variable which will cause poor outcome. Associated symptom of systemic disease, if any. In history, you go through the history generally of the cataract. It can be the duration, family history if it runs in the families, and then the visual status, how he's been behaving. Usually they come in that the child is not following light, he listens to it, but he cannot recognize people's faces. Usually what people are looking for is when they talk to them, the child reacts and he moves his eyes with them. But if we look at it, we try to see if this follows and fixates a target. If he does not do that, we'll look for his visual acuity by shining a light and asking the child to look at the light. Other ways to assess vision in very small children is an optokinetic thumb. So then you go on to birth history, which is very, very important. You need to document that. History of maternal infection during first trimester. This is to rule out the torch profile. Usually congenital cataract patients will need workup, torch profile workup by doing a blood examination. Then you go on to gestational age and birth weight, which is very important. How premature they were and how much weight they had. That's especially very important to rule out retinopathy or prematurity. Birth trauma, because obviously the body goes through hypoxia and that causes the formation of lenticular opacities. Supplemental oxygen therapy in perinatal period and development milestones. Sometimes it's just delayed milestones of birth which are associated with that. Some diseases are associated with delayed milestones. There's hypotony in patients with Lowe syndrome. So that's very important. And they have got delayed development as well. So how do you assess? What is our strategy is to get a detailed history, careful clinical evaluation. You look at the patient, you look to see the corneal reflex. If it's hazy, check for if there's any strabismus or there's any deviation of the eyes. You check for pupillary light reflex. You check if the patient has how much cataract he has. If it's a white cataract, then it's easy. But if it's not totally white, it's an immature cataract, you need a dilated fundal examination in both cases, supplemented with a B scan as well. Intraocular examination done under general anesthesia to check if cataract might be associated with glaucoma as well. Then basic assessment of child's vision, which I discussed before, and fundus examination under dilation as well, because sometimes you might have a cataract which is very mild, but he might have a toxoplasmosis retinal scar in the macula. And you do surgery for that and still the patient complains that he cannot see that. Then we go on to systemic investigations. So systemic investigations which you want are urine, and you can do a blood examination. In urine, you check for reducing substances in patient with galactokinase deficiency. Amino acid urea in Lowe syndrome, Fabry disease, and also hematuria, proteinuria, and Maltese cross figures. For blood, you check for galactokinase deficiency enzymes in erythrocytes, and then you do glucose to check for hyper and hypoglycemia, torch titers for rubella, toxoplasmosis, CMV, herpes, VDRL tests for syphilis, calcium as phosphorus for hypothyroidism. So with galactosemia, you will see urine reducing substances positive. For rubella, you will see positive antibody titers. For syphilis, you'll have a VDRL test positive. For hypoparathyroidism, serum calcium, phosphorus, and alkaline phosphatase will be raised. Wilson's disease, you'll check for serum ceruloplasmin. Hyper and hypoglycemia, you check for blood glucose. And for Fabry disease, you check for urine Maltese cross appearance. And with Lowe syndrome, you check for urine amino acids. So those are the different features which you see in these patients. So then you come in when to operate. So there are four categories. One is bilateral dense cataract, The other is bilateral partial cataract. Third is unilateral dense cataract. And the fourth is partially unilateral cataract. So in number 1 category, if you've got bilateral dense cataracts, you must operate within 4 to 6 weeks to get the best visual recovery. If it's bilateral partial, you may not require surgery or require at a later stage. For unilateral dense cataract, urgent surgery is followed by aggressive anti-amblyopia therapy. And with partial unilateral cataract may be treated non-surgically. So that is the main treatment criteria for these patients. Then comes in the timing of surgery. If there is dense unilateral or bilateral cataract, we discussed before, there is a time which is called the critical period for visual development. That is within the first 2 months of life of the child. So you need to operate within that stage. When the development, usually if you take that, the first 6 weeks is precortical stage and 6 to 8 weeks is cortical stage. Precortical meaning that the visual development is complete up to the lateral geniculate body, and cortical stage comes after that. For unilateral cataract, you should be operated by 6 weeks. Bilateral cataract, slightly larger window for about 8 to 10 weeks. So timing is very important, and counseling of the patient at that time is very important. Because the other thing which will come in, will the patient be needing glasses after surgery? Will he be wearing glasses? Will he be wearing contact lens after surgery? So that needs to be discussed with the parents, because you do the surgery, if they do not follow your post-operative recommendation for glasses or contact lenses, there is sometimes no use of surgery. So that is very important, we'll discuss. The treatment is indicated only vision is considerably impaired, especially, so you can have 2 approaches. One is non-surgical and the other is surgical. Non-surgical treatment, if there are small opacities and red reflex, is not considered significantly impaired. In some patients with small central opacity, 3 mm or less, patching and dilation with tropicamide 0.5 or cyclopentolate 0.5% can be used. Vision should be greater than 618, then no surgery is required. Surgical optical iodectomy should be considered in such cases when visual acuity improvement in chronic cycloplegic treatment. Then we come on to the surgical technique. So what are the surgical treatments? So in incision in children, the corneal tissue is less likely to heal, thus suture closure of tunnel wounds are advised. Anterior capsular access is performed and usually should be done very carefully. Sodium hyaluronate is preferred to methyl cellulose because the structures are very easily, the anterior chamber especially is very easily not maintained in these patients, and the CCC runs out pretty easily, so sodium hyaluronate usually is very recommended medication for this. Hydrodissection to remove maximal lens cortex and lens epithelial cells. Avoid in cataracts with posterior lentoconus or posterior polar cataract. The lens removal can be done with either phaco, which is rarely needed. You can do with irrigation aspiration, and usually you need to do a posterior continuous curvilinear capsular access, which is performed in children less than 6 to 8 years and any child with nystagmus where future YAG might be difficult. It is performed to prevent the PCO as it is amblyogenic, and desirable size of the posterior axis is 3 to 3.5 mm. And then comes in another thing which is most important in children, and it is different from adults, is anterior vitrectomy to prevent anterior vitreous opacification. Here we need to discuss this issue then in adults. We usually do not do a posterior capsulotomy or posterior capsular access because it is known in adults that if you get a posterior capsular tear, that the rate of retinal detachment increases. But on the other hand, in children, we deliberately do a posterior capsulotomy and anterior vitrectomy to clear the visual axis, because children cannot undergo repeated surgery, and if they do repeated surgery, then they tend to get more inflammation and the eye can be lost just due to excessive uveitis and pupillary membranes forming on the lens. So you do not have that much window for success in in children compared to adults. IOL implantation is preferably needed to be in the bag. You should plan it for the bag, because if you cannot put it in the bag, you can ideally should do a posterior optical capture into the capsule, into the CCC as well. This is to prevent the iris rubbing with the lens and causing pigment dispersion and chronic uveitis. Below 2 years, surgery is done with or without IOL implantation. It is a very big debate. Some pediatric ophthalmologists will use an intraocular lens. Some will say that you just make them aphakic and you go for a secondary IOL implantation after they are 5 or older. Because the main problem which you will get is, one is below 2 years of age, if you cannot put the IOL in the bag or manipulation is too much in the anterior chamber, the eye can just be lost. So it's recommended, if you are not at that stage, just do a simple lens extraction with posterior capsulotomy with anterior vitrectomy for a congenital cataract, and come and do and place the IOL later on in the sulcus. If you're doing it less than 2 years, multi-piece hydrophobic IOLs are ideal implantation, and you should put them in the bag. Then comes in that the predictability of IOL power calculation and visual development. That is another problem in children. So IOL power is under correction depending on the biometry and age of the child. Less than 2 years, axial length and keratometry readings change very rapidly, and over 2 years changes are slower and moderate expected myopic shift. So the bottom line is, if you do IOL implantation in children, you are bound to get a myopic shift over age. Sometimes if you implant an IOL which is emmetropic, which produces emmetropia in a child of 2 years or less, you might end up in more than 10 diopters myopia later on. That is very important, because the eyeball is going to slowly increase, and you've asked the IOL calculation to focus it just at that place where the child retina was at a very early age. So that is very important in these. So obviously there are formulas and things to handle that thing. So at birth, if you look at the IOL powers, you see that it's very high, it's 34 diopters, but when you go into 5 to 6 years of age, it reduces to 19.5. So there's a change for about 14 diopters in 5 years. So that is very crucial to what type of IOL you pick in and what type of power you pick it. So the general rule is reduce IOL power by 10% in 2 to 8 years, while reduce IOL power by 20% in less than 2 years. So here you can see if the child has an axial length of 21 millimeter, the power will be 22 diopters. So in 1 year, so you usually would do according to this chart. So early complications of surgery can happen in all cataracts, which includes endophthalmitis, patient pain, redness, reduced vision, hypopia on next day of surgery. So you need to treat it aggressively. We'll discuss it in detail in the session on management of cataract. Then you can get glaucoma, obviously in children, especially if you have surgery done below 2 years of age, there are more chances of getting glaucoma, and they need to be followed up even at later years on life. In children, if you get glaucoma, obviously the eyeball becomes bigger in size and they develop ophthalmos. Wound dehiscence can be common in children because, as we discussed earlier, the wound, the cornea and the sclera or the limbus, at the limbus, you cannot get that perfect tunnel. And if you even get that, usually the child is under general anesthesia, and because the tissues do not have that rigidity, you can get wound dehiscence or iris prolapse. Then when you do anterior vitrectomy, you have to be careful that you remove whole of the vitreous, coming into the wound and do not remove any tags. Because if there's vitreous left, there's one wick of vitreous coming into the wound. Whenever the pupil constricts and dilates around that, it pulls on that vitreous strand and that can produce retinal detachment. Late complications of surgery, which are very commonly seen in children, you get decentered IOL, posterior synecdoche formation, peripheral anterior synecdoche. Those two are different. Peripheral anterior synecdoche, you'll see the iris is encroaching up and it goes anteriorly, or at the periphery, it shelves up anteriorly and is attached to the iris. And then you have pigment precipitation, you can get IOL capture as well. So decentrations of IOL, because in children, fibrosis or healing is aggressive. That's why you get more uveitis, which we typically control by giving intracameral steroids, and you can also top it up with giving subtenon Canacort injections, because the main challenge after cataract surgery is the uveitis or inflammation, and the main problem with children is they will not let you put in drops. It will be difficult for the mothers to put in the drops. So what you need to do is you need to give them something which prevents that. Initially, we used to use oral steroids or IV intravenous steroids, but since the advent or the induction of intracameral dexamethasone into the anterior chamber, it has become very easy to control inflammation, and that tends to keep a good effect for at least a few days until your subtenon Canacort kicks in and you get reduced inflammation. Visual rehabilitation is the next most important thing in these patients. You've done a very good surgery, but the parents do not follow your recommendations. You might not end up with a good vision. He might still remain 660 at the end. So, and before going for surgery, I discuss with the parents that you the child will need glasses, because usually they have a perception, if you put a lens inside the eye, why do you need glasses? Probably you're not doing the surgery right. But you need to explain to them that the eyeball is going to grow in shape, and that is going to change the number of the refractive power. Amblyopia is a condition which can develop within the first 10 years of age. So if you do surgery for these patients, you need to regularly follow up at 3 to 6 months interval to check for their refraction and their visual acuity. And you need, after 10 years, you're not going to improve their vision. So that is very important. The other thing is using contact lenses. That is pretty difficult, is widely used in the West, but in our country it is usually quite difficult to do. Epikeratophakia, in which you can implant a cornea and transplant a donor cornea on the child's cornea as a contact lens, which produces good vision, or the patient can go without any help of any spectacles or contact lenses, but it's not very common in vogue and it's not very commonly done. The third or the last one is intraocular lens. So if you put intraocular lens, we still need glasses, but obviously the number of glasses is not going to be very high. It's not going to be an aphakic glasses. Aphakic glasses in children might go up to 15 diopters, 18 diopters plus 18 diopters. And the main problem is aphakia as such is amblyogenic, because you get distorted images and large size of the image which the child will see. So it's better to implant an IOL and try to do it, or if you cannot do it, refer to a person who is skilled at doing it. Then we come on to the problems which you can get with aphakic glasses. Even just the idea that a child who's 2 months old will need glasses after cataract surgery is incomprehensible to the parents. So you need to sit down really before surgery, and you have glasses in which you have a strap behind it to fix those in, and then the parents or children can wear. The advantage of aphakic glasses are they can be easily updated to match the rapidly changing refraction in young children. In newborn, lens power of plus 24 to 26 diopters is available, which can be accomplished with thick bubble-shaped lens. In older children, high index glasses can be used to reduce the size of the lens. High index means the lens, the material of the lens is such that it's able to refract the light rays more, so you need a thinner lens to produce the same effect. The disadvantage of aphakic glasses is lens thickness and weight as well as optical distortion. Patching of better eye is necessary when the child is using aphakic spectacles, especially in patients who have unilateral surgery. They will need to wear glasses, and on top of that, they will need patching of the normal eye. You cannot leave a unilateral cataract aphakic. You need to put an intraocular lens, otherwise making aphakia is as good as not doing the cataract surgery. Because if you have a child wearing +10 on one side and 0 and he doesn't wear any glasses on the other side, the different and isometropia, the size or the number of lens is so much different that the size of the image which forms in the retina is going to be totally distorted, is not going to mismatch. One might be 1.5 or 2 times bigger than the other, because as you know, the right eye sees, or the right brain sees from the right eye and the left eye both, half of each vision. So if one eye is showing a bigger size and the other size is not showing that, then the brain cannot join them together and make a good image, and that tends to produce reduced vision. So nystagmus development is potentially more in patients who are aphakic. Then we come on to contact lenses. They are better than glasses. They're relatively thick. They can be washed or rubbed out easily. The disadvantages are tedious for the parents. Usually they need to bring them into the hospital to get them done, associated with corneal complications such as ulcers. Most common method for bilateral and unilateral aphakia, especially in the Western world. Advantages: optical quality is much better than the glasses. Some contact lenses can be worn 24 hours a day. The lens which are available are silicone, oxygen permeability. So those are the advantage of a contact lens. Then we come on to a disease which is called rubella or German measles. It is a toga virus that is enveloped and has a single-stranded RNA genome which is 60 to 70 nanometers. It is found in the blood for 5 to 7 days after infection and spreads throughout the body. The virus transmission can be acquired by respiratory route, and it replicates in the nasopharynx and lymph nodes. And congenital infection in pregnancy is passed by mother onto the child. So it is important to differentiate that there are 2 types of rubella infections. One is acquired rubella infection, and the other is the congenital rubella infection, which is usually called a congenital rubella syndrome. So features of an adult rubella infection is you start off with a skin rash. It starts from the face and spreading to the whole body, lasting for 3 days. So you remember, 3 days rash. You get swollen lymph node, especially post-cervical, low-grade fever, joint pains, sore throat, headache, and conjunctivitis. The swollen lymph nodes can persist for up to a week. The swollen lymph nodes can persist up to a week, and the fever rarely rises above 38 degrees centigrade. So what is congenital rubella syndrome? It is the development of a triad of cataract, cardiac abnormalities, and deafness, which is sensory neural. The cardiac abnormalities which you develop are pulmonary artery stenosis and patent ductus arteriosus. Other manifestations which you develop are growth retardation, skin rash, hepatosplenomegaly, jaundice, meningoencephalitis, and CNS defects, leading to moderate to severe mental retardation. Ocular features of congenital rubella syndrome: cataract, which is very important, anterior uveitis, and then salt and pepper pigmentary retinopathy, which is seen over here, glaucoma, microphthalmos. There are multiple things. So rubella is actually, when it started off, there were about 30,000 mothers who were affected with it and children who were affected with this in the United States at that time. But now it's been controlled by the MMR vaccine, which every child gets after he's born, and then he gets a booster later on. So it's a live attenuated virus, so you get antibodies against this throughout your life. So rubella virus can cause fetal damage, especially if the infection occurs in the first trimester of pregnancy. Live virus particles may be recovered as late as 3 years after birth. Pearly white opacification and the entire lens is opacified and cortex may liquefy. Cataract removal may be complicated by excessive inflammation because they say sometimes the viral particles are entrapped in the lens and they are released when you're doing cataract surgery. So you have to be prepared to counter excessive inflammation in these patients. So it's important to do torch profile in patients who have cataracts, especially congenital. So in conclusion, visual rehabilitation of congenital cataract is a multi-stage process and counseling of the patient is very, very essential. If you do not do that, you will run into a lot of trouble. And it is probably what I tell my patients is probably I do half the work, probably more than half is done by you, because you have to be with the child and to make him wear glasses, and you have to bring him all the way every 3 monthly for follow-up and to get his visual rehabilitation. But treating cataract surgery in children is a big responsibility for the surgeon. You should take it very honestly and you should follow it up and try to do your best to get the best visual outcome. A handicapped child is going to be a liability on the society. So you need to get these cataracts right and get them rehabilitated. Although the visual recovery is not as good as an adult cataract and a congenital cataract, but now with advanced technology, they can go up to 6.6, 6.9 pretty easily. But that's why pediatric ophthalmologists are more and more doing these cataract surgeries. Thank you very much for listening. Subscribe to our channel to get the latest updates, and we'll be back with the next module soon. There'll be assessment along with this lecture, and we'll give you a link later on. Thank you.